I invite Dr. Saikumar, sir.
Thank you. Thank you, Sinimol, for having me in this course. I'm sorry I was a bit late because the executive committee meeting was going on. So I'll be talking about two very specific clinical conditions in which you encounter small pupil. I haven't heard the previous talks except the last bit of JP, but I'm sure most of the devices and techniques would have been already covered. So I'll just briefly go through this. So IFIS was originally described by Chang and Campbell about 2 decades back. It was seen predominantly in elderly males who were taking alpha blockers for benign prostatic hypertension. We all heard about the drug tamsulosin, which was widely used. And then we also found out that alpha-zosin, terazosin, silodosin, which is being very commonly used nowadays, which is now the urologists prefer more of silodosin. But all of them can cause IFIS. There are some drugs like benzodiazepines and antipsychotics which can be used. We are not sure whether stoppage of the drug does make any effect. I have found that stoppage does not make any change, so I don't stop alpha blockers at all for my patients. There are some patients who believe in pre-op atropine. Again, it might work in some, but not a very sure shot to prevent IFIS. The components of IFIS are progressive meiosis during surgery, fluttering or billowing of the iris, and prolapse of the iris either through the main wound or through the paracentesis. And if you are caught unawares, IFIS can be a pretty nasty complication during phacoemulsification. But if you are aware of it and you have taken preemptive measures, then it is easy to manage. So how do you handle progressive meiosis? Preoperative dilating agents, of course. Preoperative NSAIDs, if you are not using it regularly, I suggest that in cases where IFIS is expected, you have to use them. There are many surgeons who use atropine. I don't use them regularly, but surgeons who use it claim that the pupil does not come down too much. Intraoperative adrenaline I use in all cases where I suspect IFIS. Judicious use of dispersive viscoelastics to me is the most important step. I use only Viscoat for this condition, no financial interest, but I find this the best drug to keep the iris away from your surgical field. And of course, all the devices that are being discussed now. How do you prevent the fluttering and billowing of the iris? Again, dispersive OVD is very, very important. Reduce your phaco parameters a bit, although I don't use this in every case, but in severe cases, you can make it look like a slow motion phaco so that the flutter or the circulation of fluid inside the chamber is come down. And you can also prevent iris chafing. Don't go, take out the pieces, remain in the center, don't go too much to the periphery where you can catch the iris. Small iris prolapse, of course, make your side ports and the main wound very tight, just enough for your instruments to go in, and be very careful when you go in and come out with the instruments. And again, OVD, dispersive OVD is a very, very important component. So let us look at 2-3 clinical scenarios. This was actually an ex-minister in Kerala who wanted only femto. His pupil was reasonably well dilated, good enough for femto. So we went ahead and did. He also wanted a toric intraocular lens, but we knew that he was on tamsulosin for a long period of time. So here I am just checking the edges of the rexis, whether they are intact. I don't routinely make the main wound with femco in all cases, but the moment I started my hydrodissection, then the iris starts coming down. Immediately it is trying to prolapse out through the main wound, and now this is where I am using Viscoat. So use Viscoat to just push the iris away from your surgical field and go ahead and do a routine phacoemulsification. It won't cause any trouble for you as long as the iris is kept away from your surgical field. Even during the surgery, you find that the iris is fluttering a bit, but it won't cause any significant problem, either during your phacoemulsification or during your cortex aspiration. You can see that the iris has got a tendency to come into the bimanuals, but you can manage without any major complication. So we'll go to the next scenario where the pupil was mid-dilated, and so I used a B-hex ring. I use a micro forceps which is used by our retina surgeons to put in the ring. Just put in the ring like that, and then use a dialer to tuck the ring under the iris. This is the technique that I use. This technique is good in my hands, although there are some forceps that are described by Suven for placing these rings under. I generally use the the microrhexis forceps the VR surgeons use and probably discard, and you can take it. And even for removal, you can use that. So the iris remains well there. I'm not going to show much of the phaco part here. This patient also opted for a toric lens. And at the end, you can just use the same forceps to just take out the ring that way. This was a case which was managed by iris hooks. This was slightly older video. This particular case, probably I would have used a B-hex if I do it now. I usually use for IFIS, I use 5 hooks. So use a paracentesis just before, underneath your main wound in a different track, and through that your 5th hook goes in. So you have something like a pentagonal iris that is available for you, and this is how the iris looks like once you place the 5 hooks. Initially, I was also skeptical of putting in the, the 5th opening underneath your main wound, but it does not interfere with your phaco or IOL implantation in any way. So these are the ways in which you can manage the IFIS. So the take-home messages for IFIS is that duration of alpha blocker use has no connection. Even patients who have been on 2 months, you can have IFIS. Some patients who are on 5 years, you may not get IFIS. So once you know that this patient is or was on alpha blockers, we recently had 2-3 patients who already undergone surgery for prostate 2 years back, but they were using tamsulosin at some point of time. They also had similar IFIS. Pre-op pupillary size is important. Sometimes even normal pupils can come down, but smaller the pupillary size, the more the problem. Elderly people already have myotic pupils. If they are also on tamsulosin, it adds to the problem. Judicious use of OVDs devices. Never do sphincterotomy or stretch pupilloplasty if you're suspecting IFIS, because it will make the iris more, pliable. It will cause more of billowing. Coming to the second, which is pseudo-exfoliation, I call the iris pattern, there is something called a fragility spectrum. So if the IFIS irises are thick and mobile, the pseudo-exfoliation comes somewhere in between. The uveitic iris is very fragile. The moment you just open it with your sphincterotomy or your Kuglen hook, they just stretch. There is a lot of sphincterotomies and it just remains that way. Pseudo-exfoliation is somewhere in between. There is degeneration of iris muscles, atrophy of the pigment epithelium and stroma. Shallow AC is a problem that you quite often encounter in pseudo-exfoliation. So unlike in IFIS where you handle only the iris problem, you have endotheliopathy here, you have shallow AC here, you have possibility of weak zonules here. So a lot of multiple issues you have to tackle when you are doing a pseudo-exfoliation case. This was a mid-dilated pupil, not a very small pupil. I did a rhexis but found out that the whole nucleus was moving around. I managed to do a complete rhexis, but here instead of using an iris hook, directly go in with a capsule hook, so that both your iris and the capsule are very conveniently caught in your hook. This is an external tamponade, as I call it, so you can safely do your phacoemulsification, and towards the end you can go in and implant a capsule tension ring and then go in with your intraocular lens. And while taking it out, please be careful not to hook the edges of the anterior capsule while you are taking out the hooks. This was a case where there was pseudo-exfoliation, small pupil. As I mentioned before, pseudo-exfoliation, you can do sphincterotomy. You can do a stretch pupilloplasty in these sort of cases. So here I try to stain the capsule and use a stretch pupilloplasty here. It behaves something like a uveitic iris. It's not like a IFIS iris, so you get reasonably good dilatation. The moment I started the rhexis, I found out that the entire nucleus was moving around. So this is hook as you go. That means you have a bit of a rhexis you do, put one capsule hook, do some more of the rhexis, put the second one, the third one, like that you can go ahead. This particular patient needed a sutured CTR because the whole nucleus was very, very mobile. The third case is a case where, again, I thought I'll do a bit of stretch pupilloplasty and get away with a routine phacoemulsification. Luckily, the iris did not tear too much, because finally I would require this iris. The moment I started doing my rhexis, I found out that the entire nucleus was wobbling around. There was no way I could do a proper rhexis or a phacoemulsification in this case, and the nucleus was very hard also. So I aborted there. I made a scleral tunnel and I went ahead and removed the whole nucleus with a vectis. you can see the edges of the zonules which are very, very weak and stained with trypan blue there. Went ahead and did an inferior PI and went ahead and clawed the, used an iris claw lens. So for iris claw lens, you should not create multiple sphincterotomies. If the pupil becomes very ragged, it becomes a bit tricky to put in an iris claw lens. But here, fortunately, the iris was a bit pliable. In spite of my stretch pupilloplasty, the iris was reasonably okay so that I could implant a claw lens. So take home points regarding pseudoexfoliation. You have to deal with multiple issues here, like a small pupil, weak zonule, shallow AC, and it's very well documented that pseudoexfoliation patients do have significant endotheliopathy. They do have significant problems with the corneal endothelium. Capsule hooks may be needed instead of a normal iris hooks. Use of CTR in all pseudoexfoliations used to be recommended a decade ago. I don't know how many of you regularly use a CTR for all pseudoexfoliations, even if they have weakness or not. There used to be a time when we all used. I found that over a period of time, it did not have much effect because many of the pseudoexfoliations I did 10 years back, 15 years back with all these things, the entire bag, the iris, the IOL, the CTR, everything started, falling down in some irises. And stretch pupilloplasty is not absolutely contraindicated in pseudoexfoliation, unlike in a case of IFIS. Thank you for your kind attention, and thank you, Sinumol, for having me in this course.
Thank you, Dr. Sai sir, for that excellent talk and excellent videos. And one point we have to be very careful is that no stretch pupilloplasty in floppy iris, but we can do it in pseudoexfoliation. And about the sonular dialysis possible for pseudoexfoliation, we have to be careful. And then iris claw IOL becomes a better option.
When you have really, if you are really going in to remove the nucleus, if you think that phaco just cannot be done, then don't manipulate the iris too much from then on, because you always have this backup of, otherwise you will have to go in for a sutured seat, SFIOL
sutured
or a glued IOL, take, open the sclera, make flaps and things like that.
Okay, sir. The session is over. We can have a short discussion. JP, sir.
Can I ask a question? Hi.
Yeah, Sudeep, hi.
You mentioned putting a CTR in one of your videos with generalized subluxation. So would you think of putting a CTR in the bag and putting a 3-piece IOL in the sulcus in front of that?
This is what we, in that particular situation, I implanted in the bag. But we have been doing quite, in our institute, we have been doing quite a lot of cases where we put in the CTR, then place the IOL on the sulcus and then capture it.
Yeah.
So probably long-term stability is
More.
better with this
The whole
sort of
thing
lenses.
doesn't go down.
The only thing is you will not be able to use a single-piece lens. If you are using a 3-piece lens,
Yeah.
use it in the sulcus. Point taken.